Hi, welcome to the Orthobiologics podcast. I am your host, Dr. Trevor Turner, MD, RMSK. Welcome to episode 11 that is titled, What's the Deal with Fats? Today, we're really excited to be joined by two prominent physicians who teach other physicians about how to use orthobiologics all over the country. Please join me to welcome Dr. Mary Ambach and Dr. Chris Rogers, who are both board certified in physical medicine rehab and fellowship trained in interventional pain. They're recognized experts with over 10 years of experience in the field and more than 30 years of experience in orthopedic medicine, and have both served as faculty and speaker at numerous conferences, both nationally and internationally, and are also published in medical journals as well as textbooks. Dr. Chris Rogers is also co-founder of Data Biologics, which is a regenerative medicine registry used globally, harkening back to some of our prior episodes where we've talked about how important it is to keep data and keep outcomes. He's also the medical director of Personalized Stem Cells, which sponsors FDA-approved clinical trials on using autologous adipose-derived cell therapy, or cells that we derive from our fat. And so as we jump in today, we're going to talk more about how both Dr. Ambach and Dr. Rogers use these types of treatments to affect knee arthritis and degenerative disc disease in the low back. They're located in San Diego, and their medical group is also in Carlsbad, California. Thank you so much for joining us both today. We've kind of talked in the past on our episode about bone marrow versus fat versus PRP. And there's really been a heavy emphasis on using mesenchymal stem cells from the bone marrow. So, Dr. Ambach, do you want to chime in a little bit about why people even consider using fat to treat orthopedic issues at all?
So, there's a lot of differences with regards to bone marrow and fat. And I think the main difference is that the adipose tissue or fat tissue has more of these mesenchymal stem cells than the bone marrow tissue. Comparing it with the same volume. So the mesenchymal stem cells, these are adult stem cells that has the capacity to regenerate into bone, tendon, cartilage, or muscle tissue. And in the adipose tissue, these mesenchymal stem cells, are what we call the MSCs for short, comprise about 1 to 15% of the nucleated cells, or the cells in the adipose tissue, while in the bone marrow, it only comprises about 0.001 to 0.01% of the bone marrow tissue cells in the nucleated cells. So that's, I think, is the main reason why we are using this therapy for our orthopedic patients.
So what it sounds like you're saying is, if I took an equal amount of fat from a person and I took an equal amount of bone marrow and I was trying to analyze how many stem cells we were able to find in the same amount, that actually there's a possibility you'd find quite a bit more in fat. Is that what you're saying?
That is correct. Yeah, there's a great variability of the numbers. So it's hard to delineate actual numbers on how much you can actually find. Dr. Rogers may be able to give you some numbers, but suffice it to say that the adipose tissue does contain a great deal more of these mesenchymal stem cells than bone marrow for the same volume.
I see. And so, Dr. Rogers, there's a lot of people who are using fat, I think around, well, probably outside the United States as well, but who are using it in the United States, and they're using kind of a machine to try and process it, to be able to get to those cells. And maybe that's a little bit different than the kind of work that you're pioneering at PSC, but tell us a little bit more about kind of what's unique about what you've been doing.
Yes, really important to understand that when we talk about bone marrow or we talk about fat, there are many different subcategories that you can consider. So when we say fat, it's a little bit like saying vegetables are good for you. There are many different kinds of vegetables. I actually like to use the analogy of my favorite breakfast cereal as a child, Lucky Charms. You may remember Lucky Charms has these crunchy oat bits that nobody really likes. But then the part that makes it magically delicious are the marshmallow bits, right? And so when you take fat, when we perform lipoaspirate, we obtain some fat tissue from the patient. It's kind of like that bowl of cereal. It's got all kinds of different ingredients in it. And then you can go on to process that bowl of cereal to either pull out just 4 or 5 different types of the marshmallow bits, or you could even pull out just one type, like the blue diamonds. And in a clinical study under an FDA regulatory environment, you could actually culture those cells. So it's important when you're reading about adipose that you understand what we're talking about. And so to use the analogy, microfragmented fat, which you may have talked about on this program, would be analogous to taking that bowl of cereal and sort of rinsing out the milk, which you don't really want, and maybe rinsing away some of the oat bits that you don't want. And so you hope that there's some good marshmallow bits in there, although you're not really counting it at the bedside. That's what microfragmented adipose tissue would be, of which there's different devices that are 510K cleared devices. These are approved devices that process. Then to take the analogy further, if you were to just want to pull out the marshmallow bits, maybe just the moons and the stars and the diamonds and the green clovers, to get those marshmallows isolated, you have to then subject the adipose tissue to an enzyme digestion and a centrifuge process so that you can separate the cells.
Okay, and so tell me, Dr. Rogers, when you say enzyme digestion, what do you mean by that?
So there are different enzymes that can be used that digest the collagen, the protein fraction of the adipose tissue, to release the cells from the adipose tissue. So adipose tissue by volume is about 90% adipocyte, so it's fat cell. It's actually a very small fraction by volume that constitutes the cells that we are after. Understand, by the way, you say, why does fat even have these cells in them? All tissues have these cells in them as long as there are blood vessels, right? So the MSC that Dr. Ambach was talking about clings to the outside of the blood vessel. It's called a pericyte at that point. And it can be released from the blood vessel, released from the collagen tissues by using different enzymes. And then now that can no longer be performed. It has in the past, but it can no longer be performed at the bedside. So unless you're involved in a FDA-approved clinical trial, such as the study Dr. Ambach and I are involved in, the FDA really doesn't permit this anymore in the clinic. And there's a variety of reasons for that.
Yeah, so that's a key distinction. I think when we talk with patients about what's compliant with the FDA and what's not, to avoid maybe some people who are advertising about the use of stem cells in ways that may not be safe or appropriate. So as a key distinction, maybe could you give me a little bit of detail just about the effort and the requirements and how long it took and how much you had to do to be able to come a registered site for an FDA-approved clinical trial and what that's really like?
Yeah. So you're too young to be on any medications, but some of our listeners may have medications in their drug cabinet in their home. Every one of those drugs had to go through a vetting process for safety and for efficacy to earn the badge of FDA-approved drug. And before you even get to that stage, you have to have FDA approval to even conduct studies on what's called an investigational new drug. So the FDA considers the process that I just talked about, where you take the fat and extract the cells using enzymes as a drug manufacturing process. So it's regulated in a way that requires manufacturers to submit an application and some evidence to suggest that it's safe and it has some efficacy. Now, our sponsor, Personalized Stem Cell, the sponsor of this clinical study that we're currently involved in, has a long track record using cells from fat in the veterinary world. So VetStem is the parent company that has been using this biologic since 2002. So we were able to use those thousands of patients, those animal patients, their data, the safety data, to submit what we would call preclinical data to the FDA. So then the FDA would allow us to perform a phase 1 safety trial on humans, which is the study we're involved in right now.
Wow, so that's excellent. So so there's kind of a big difference between just recruiting patients for a study and actually being regulated like a drug, like a pharmaceutical. And so, to me, when I look around at people around the country who say, oh, we're running a clinical trial, and we start to ask questions. Well, are you registered on clinicaltrials.gov? Have you submitted an investigational new drug application? And obviously, that's the route that you guys have taken, and we're grateful for it, because that's the kind of work that ultimately is gonna change the field and make really pioneering therapies like this, number one, safe for patients, but also number two, available and kind of with enough data to support their use on a larger scale. Um, so Dr. Ambach, when you started performing orthobiologics, and I'm assuming you probably started learning applications of bone marrow derived therapy and PRP, as well as adipose or fat derived cells. And I just would like to know more about how the pattern of your practice maybe has changed with the addition of the use of fat harvested for the treatment of musculoskeletal or orthopedic issues in the past few years.
Yeah, that's actually a very accurate description. I started to use a lot of platelet-rich plasma and bone marrow-derived cell therapies, and later on just incorporated adipose cell therapy. And the conditions or the patients where I start to consider adipose cell therapy are mainly two areas, because as we know, we have already established that there's more number of mesenchymal stem cells in adipose tissue, and we also know that as we age, there's a decrease in this number of mesenchymal stem cells, both in adipose and in bone marrow. So when my patients are older, usually about 65 years old or older, I start to think about using adipose cell therapy, and I favor this therapy because of the number of cells. So of Dr. Mautner's study comparing bone marrow and adipose derived cell therapy for osteoarthritis, and they basically showed no significant difference in improvement for using bone marrow concentrate and adipose. So, patients who are middle age, for joint and tendon injuries, bone marrow concentrate and adipose derived cell therapy will probably result to the same, at least in my clinical experience. In fact, for this population of patients, I usually offer bone marrow first because it's got the additional platelets in it and the growth factors. But when the patients are older or even in more significant advanced pathology, like rotator cuff injury, for example, is the second condition that I tend to favor using fat for more advanced rotator cuff tear and rotator cuff injury. There's studies by Striano on using Mfat or microfragmented adipose tissue for patients with rotator cuff pathology that did really good on their 1 year clinical outcome. There's also study on using ASCs, enzymatically prepared ASCs, on patients with partial rotator cuff injury. And not only did they improve in clinical outcomes, they actually showed MRI changes of up to 90% reduction in the tear. And Dr. Rogers and I have, patients that even surprised us that they did get any improvement, and ultrasound changes, evidence of ultrasound changes in their rotator cuff tears that are pretty significant, in anywhere from 50 to 70%. I had a patient who was a fireman, and he was also a jiu-jitsu trainer who had 70% rotator cuff tear, and I was frank with him with the possibility that it may not work, but he was determined to actually not undergo any surgery. So we discussed all the possible options, and we went with the fat derived therapy. And at 4 months, we can already show changes in the tear, and at 6 months follow-up, he was probably about 70% improved in the rotator cuff tear with significant improvement in function. Initially, he wasn't able to even lift his gear while working,
Wow.
and at that time, he is able to. And Dr. Rogers can tell you about his professional athlete that did significantly well with this rotator cuff tear using Mfat.
Sure. And so to be clear, the clinical trial that you guys are working with is a little bit different from Mfat, just on the account that you're using the actual chemical process as opposed to just passing through kind of a filter. Is that right?
Yeah, it's very important to distinguish the two different biologics. So Mfat, we use a device called lipogems. It essentially rinses and washes the lipoaspirate. So you remove some of the fat and the oil, some of the oil and some of the blood residue, and then you resize it. So you mince the fat into smaller pieces so it's easily injected. We talked about the number of cells in a typical dose. So if you think about 2 teaspoons of bone marrow, that'll probably get you about 5,000 of these MSCs that you want. If you think of 2 teaspoons of this microfragmented adipose tissue, you can probably get about 500,000 of these MSCs. If you then go on to digest with enzymes and centrifuge, which is, you can't try this at home, you can't do this in your office unless you have FDA approval to do this, we typically get about 5 million of these cells. So it's a substantial increase, and dose does matter. The other advantage, and in full disclosure, as you mentioned at the top of the show, I'm medical director for this personalized stem cell company, but I'm also a consultant for Lipogems, which uses the Mfat, the microfragmented adipose tissue, and I've used that product for 5 years. So I've seen good results with both, but I think the other advantage of processing the tissue in a lab is that you can test for sterility and you can test cell count and things like this. So you can actually quantitate the dose that you're giving to the patient. Nonetheless, with the Mfat, with the microfragmented adipose tissue, the type that where we rinse and wash the adipose tissue, as Dr. Ambach just mentioned, we've used it in many high-grade tears, tendon tears, rotator cuff, gluteus medius, Achilles tendon. Our experience is actually ahead of the published literature. We have a number of patients where we've shown MRI and ultrasound changes where the tendon is significantly healed, but there aren't a lot of good published studies yet with microfragmented adipose tissue for tendon tears. But you'll see there'll be some. You'll see them.
Yeah, we eagerly await the results of that study, especially the pictures. That sounds really great. But yeah, that was one of the things I think early on when we first started the podcast, is we talked about just how much more data there was for bone marrow, but that obviously people are excited and interested in adipose or fat because of the potential to yield higher cells. So let me ask you about that. When we consider your clinical trial, it's interesting that it looked like the 2 big things that are enrolled for treatment in that are knee osteoarthritis as well as lumbar disc disease. That's what the trial is primarily around?
This trial is just for knee osteoarthritis. So for
right.
KL 2 to 4, knee osteoarthritis in one knee. They can't have symptomatic severe arthritis in the other knee. We will obviously expand. Our next study that we intend to apply for with the FDA will be for the treatment of zygapophyseal joint or facet joint osteoarthritis, so back pain due to arthritis in the back. And so we're looking forward to doing that.
Great. And then, you mentioned something KL 2 to 4. Can you describe a little bit about what that means for people who wonder whether or not their knee sort of meets criteria?
Yeah, that's a great point. So we grade the severity of arthritis based on the appearance of the radiograph. And you can argue that's actually not a very good way to grade severity of osteoarthritis, because we know that x-rays don't correlate very well with clinical symptoms.
Patient's pain, yeah.
Exactly right. So you can, if you inject steroid into a patient or a local anesthetic into a patient's knee, their x-ray still looks terrible, but their pain is gone. So there's obviously a lot more to the story than just a simple radiograph. But this is traditionally how it's been done in literature. We stratify patient severity by this Kellgren-Lawrence scale, 1 through 4, with 4 being the most severe. And this is very important to keep in mind for those scientists who are out there reviewing the literature. When I look at some studies, they're treating mild disease. you can't compare those results with a study that is looking at more severe disease. So it's important to keep that in mind.
Yeah, certainly. So, and then other than the severity of disease, so I know Dr. Ambach, you talked about having kind of a really high percentage of a rotator cuff tear. You talked about people's age maybe being a factor about whether you'd consider fat versus bone marrow. Do you find that there's other things? I mean, are there patients that when they're coming in to talk to you, that they're leaning one way or another? Are they more interested in fat because they think or they're worried that maybe bone marrow will really hurt if they get an aspiration? Or how does that conversation usually go?
Yeah, that's interesting, actually, because we get that a lot whenever we offer, bone marrow source versus a fat source, and as understandably so, patients are always more willing to donate their fat rather than to have their bone marrow aspirated. So one factor to consider is actually the patient's choice. You tell them what information is out there in the literature and what research supports, but ultimately, they will decide on what they want to do. Both procedures are actually pretty well tolerated. Both bone marrow aspiration and lipoaspiration are pretty well tolerated without sedation. Usually we just use a mild analgesic and a local anesthetic, and patients tolerate it really well. So patient's choice is one factor. Another factor is actually the availability of the tissue. Patients who don't have fat obviously will not be good candidates for the therapy itself.
Yeah, I know there was a case presentation, I think it was a couple of years ago, maybe at the Orthobiologic Institute meeting, and a really, kind of a renowned, very professional physician got up and talked about, potential complications of fat harvesting and liposuction and bleeding, and kind of, I think probably a lot of people who were there that are, experienced in the field kind of looked at that and said, wow, that one took a lot of courage, but two, gives us something to think about how we choose whether or not, fat or bone marrow is going to be the lowest risk and type in terms of how we treat our patients. So,
right. I think that was Dr. Mulvaney who presented that case. Yeah, Chris, probably you probably had more cases using the gluteal adipose tissue. I use both adipose and gluteal fat, and it's definitely something to think about. But it's a superficial injection, and fortunately, we haven't had those kinds of complications.
We, if I may jump in. I've done more than 300 of the lipoaspirate procedures, and hopefully there's some wood to knock on. I've not had a complication. You mentioned at the top of the show, we use a registry called Data Biologics. In that registry, patients can report adverse events for up to 2 years after their treatment. So this, we would think this would be something that the FDA would really like all doctors to do, is to have a HIPAA compliant way to report adverse events without having the physician interfere with that data. So I've reviewed all these cases, and to the question of which is more uncomfortable, it's pretty equivalent. The lipoaspirate is about as equivalent on average a 2 or 3 out of 10 pain compared to the bone marrow, both during and after the procedure. And then in terms of adverse events, you think about hematomas or other complications, infections, et cetera. We've just not had any thank God, with any of our procedures, we've not had any, but we are tracking that data. I know in the published literature, there's some concern about the risk of lipoaspirate, but you have to understand that those studies are looking at plastic surgery procedures where, you're removing 2 pounds of fat as opposed to, we're removing 2 tablespoons of fat.
Smaller,
So it's a completely different scenario. Now, our patients are older, right? So there may not be a lot of 70-year-olds getting plastic surgery, but and most of our patients are older who have knee arthritis or rotator cuff tears. So it's important to collect this data. But so far, the safety has been very good.
excellent.
Yeah, I'm sorry. I just wanted to expound on that, Dr. Rogers. As you said, all the data on adipose harvest complications is based on studies on liposuction surgery. And even patients who are coming to our clinic are thinking that we're going to do liposuction on them and it will actually give them a better look. And I always have this discussion with them. We're doing the difference between a liposuction surgery and a lipoaspiration. First is the volume. They do aspirate liters and liters of fat. One study that studied the complication of this liposuction surgery had an average of 5 liters of aspiration, and that's usually typically what they aspirate. Whereas for our lipoaspiration procedures, we use maybe about 40 cc for doing a joint, or even less. So it's significant difference in the amount. Also, for the liposuction surgery, they typically use a vacuum or a mechanical suction for their lipoaspiration. And even some of them would add an ultrasound or a high frequency sound wave to liquefy the fat before they aspirate it and connect it to a mechanical device for aspiration. So that adds, more trauma to the tissue. In the lipoaspiration procedures that we use, we only use a small syringe with a vacuum syringe pump in it, and that's basically very minimal injury to the tissue, if at all. Their cannulas are also bigger, and the tumescent, which is that liquid that we inject in the soft tissue to anesthetize the region, is also different. They have a bigger volume of injection of the tumescent, and their epinephrine that they inject is higher in volume, so that's why they have tissue necrosis as one of the reported complications. And we don't see that a lot because we really inject a very small volume, usually around 200 cc of this tumescent as compared to their liters of tumescent that they inject.
Yeah. So to summarize, it sounds like what you're saying is, we use when you perform the lipoaspirate to get those cells from the fat, you're using a different size needle, using different kind of anesthesia. You're pulling out a much lower volume or a lower amount than a typical plastic surgery would be. And so that may be some of the reason that you feel, in your case, that both you and Dr. Rogers and maybe other experts who do this procedure have not had a high complication rate, because compared to maybe a big surgery, it's really kind of a lower risk type of procedure, it sounds like.
And that's exactly right. It's a good summary, and that's as it stands today. Can I give you a little peek into the future?
Please.
So in the very near future, we will be able to harvest maybe a teaspoon of fat, maybe 5 grams of fat, a very minimal procedure that would take 20 minutes, perhaps.
Wow.
That fat can then be transported to a GMP facility, a FDA-inspected facility, and instead of getting 500,000 or 5 million cells, we can get 10 or 20 million cells by growing them culture expansion in the lab. Now, of course, that all has to be done under FDA-approved clinical trials, but we will be doing that work where we will harvest a very small volume of fat and then generate very high number of cells. And the real beauty of this, I think, is not only do you have a sterile, well-characterized biologic that you know exactly what's in the bottle, right? So you as a physician would get in the mail a vial of frozen cells. However, when you culture expand, you can now generate 100 or 1,000 vials. So that patient can have a very large number of treatments in the future. So with one single simple harvest, you can do repeat treatments or treat additional body parts. Of course, we have to do the work to show that that's going to be safe and effective.
Yeah, absolutely. But, we definitely have patients come and ask questions and say, okay, well, I know, or, based on your data that, you have an expectation that this type of treatment for knee arthritis is going to give me, 4 to 5 years of significant pain reduction and functional improvement. But what's going to happen in 4 to 5 years? And, usually we have a discussion about, there's a chance that you're going to need an additional procedure, depending on other risk factors and activity modification and some other things. But people want to know, am I going to have additional treatments in the future? And I think if patients had the ability to do, kind of a one-time harvest and then be able to use those cells almost kind of in perpetuity, or, be able to use them for multiple issues in the future, they'd be really excited about it. I'm going to shift gears for just a second. There's a lot of physicians, when they're reading kind of guidance from the FDA about what we're able to do and what we shouldn't do and what's permitted in the United States, that there's a concept we've talked about before on the show called homologous use. And it's kind of related, I guess, to this idea that we should use tissue that is alike in the same kind of function as we should, if we're going to be taking it from one part of the body and maybe putting it into another part of the body. And physicians themselves kind of have some, they have conversations about whether or not all of the tools in orthobiologics are satisfying that requirement. And you guys have tremendous expertise and, kind of talking with the FDA and understanding how to interpret maybe some of those guidances. What would you say about the comment that using fat for, whether it's a rotator cuff tear or knee arthritis, kind of meets that criteria?
It probably doesn't, in the strictest sense of the FDA description of homologous use. In the case of microfragmented adipose tissue, as I mentioned, it is a 510K cleared device, which is intended for homologous use and does satisfy the minimal manipulation requirement that allows us to use it in the office. But homologous is a term that means that the tissue is being used in the way that it would be used in its natural state. So, for example, if someone had a coronary artery bypass graft and a vein was transferred from the leg to the heart, you say, well, that vein is still functioning as a vein. Or in the case of a ligament transplant, it gets a little fuzzy when you start talking about adipose tissue, and the FDA has issued some guidance as to what they mean, and they're talking about structural homology. So the language we use is we say that these tissues, their intention is to cushion and support and to facilitate a healing environment because they contain cells that can promote healing. But those of us outside of the FDA's definition, the structural definition of homologous use, an argument can be said that there's also a cellular homology, right? So these cells, these MSCs, these pericytes, they live on blood vessels in every tissue in your body, and so the question is, does removing that cell and putting it in another part of the body, is that a cellular homology? But that's not an argument that plays well with the FDA. So the FDA is very clear that they have a very well-defined definition of what homologous use, and that's based on the structural properties of that tissue. When you start talking about putting these microfragmented adipose tissues in tendon, it gets really difficult to support the notion that you're cushioning or supporting that tendon, but you can make the argument that you are facilitating the healing environment of that tendon tear. I think we're going to get more and more clarity on this language going forward after November. So it'll be interesting to see how this all plays out.
Yeah, absolutely. And, I want to, we had the privilege last week of talking with Dr. Saramat Lurie out of Ohio, and we were talking about the use of specifically bone marrow concentrate to be able to put into discs, and lumbar degenerative disc disease, and just kind of how it was really seeming to revolutionize the treatment of a problem that, is an enormous burden on the U.S. healthcare system, is an enormous burden for patients with chronic back pain who've really failed, an abundance, a huge number of kind of the more conservative treatments maybe that we have out there. One of the things that came up that we were talking about is the risk of discitis. And I talked with, another expert in the industry who said pretty much almost everybody he knew that was, elitely skilled and trained enough to be able to inject biologics into discs at some point has had at least one case. And we've talked kind of about PRP and bone marrow. Have you, in your experience, seen that with fat maybe derived cells? Is that risk any lower, or is it safer? How do you respond?
Well, I've been injecting the disc since 1997, and I'm happy to say I've not had a case of discitis. Usually we were injecting the wrong thing. We were injecting contrast or local anesthetic or putting wires into the disc. Now we pretty much focus on bone marrow aspirate concentrate or PRP. There is a concern that we always have in that, in the FDA sense, we're manufacturing these biologics in our office, and if you're not careful, there is a risk of contamination with bacteria or other organisms, and causing a discitis. There, Greg Lutz, who has a lot of experience in this area, presented some information recently and suggested that the risk might be higher with the bone marrow aspirate concentrate versus PRP in his experience, and talking with other physicians who have experience in this area, whether that's a result of the fact that there's a little more manipulation involved in manufacturing the bone marrow aspirate concentrate than PRP, it remains to be seen. These biologics are also different. Maybe they have more or less protection against infection based on the content of that biologic. There's almost no evidence whatsoever for adipose in the disc. We don't do it. I don't recommend it until somebody does a study that shows it's safe. And then we have to characterize. I don't think I would put a Mfat into the disc, although I know some have. I feel better putting something like stromal vascular fraction, which has been tested for sterility and comes in a bottle, or cultured adipose cells, which come in a bottle and have been tested for sterility. I feel better about doing that. And maybe in the future we will study that, or others will study that. But there's not enough published evidence for me to feel comfortable doing any of those things.
Technically, too, it's just harder to inject that microfragmented tissue into a disc. It's hard enough to inject PRP and bone marrow, which is more liquid state. Just imagine injecting an Mfat into a disc. That would be very, very difficult to do. That bone marrow, that study, Dr. Turner, that you were alluding to regarding degenerative discs, that's actually a multi-center trial that we are doing with Dr. Navani and Dr. Rosenthal and Dr. Kolodny for the use of bone marrow derived cell therapies and PRP into the discs.
Fantastic. I want to take this time to thank you both, Dr. Rogers and Dr. Ambach, for joining us today on the Orthobiologics podcast. This was episode 11, What's the Deal with Fat? If you want to find out more about Dr. Rogers or Dr. Ambach's practice, you can check them out at www.sdomg.com. They are the San Diego Orthobiologics Medical Group. You can find them on YouTube, you can find them on Facebook, and you can find them in Carlsbad, California if you have a treatment and you're interested in understanding more about whether fat can help you. I am your host, Trevor Turner, MD, RMSK. Thank you so much for joining us on the Orthobiologics podcast, brought to you by Georgia Bone and Joint. Check us out online or at Facebook, and we look forward to seeing you next time. Thanks a lot.